it's also possible to anchor this implant more in the midline. There's also a lot of bone. I think I have a picture here. This picture is from Dr. Dobrinin. He works with guided surgery, and of course with guided surgery it is quite easy to reach this target bone. So this is a typical 6C. As you see, he combines in this case with a zygomatic implant. This picture shows how this is done on the skull. So the implant enters the alveolar bone, it goes out from the alveolar bone, and it goes into the floor of the nose, as you can see here. It's another option. 60. Okay, and finally, seventh discipline, upper canine bypass. This is of course also a subdivision of method 3, engagement into the floor of the nose. This implant bypasses the canine on the palatal side and anchors up there in the floor of the nose. It works only if there is on the palatal side of the canine, if there is bone. Not everybody has this. You can palpate this, or palpate with a needle, or do a CT than you know before. Here's an example of this. So this implant bypasses the root. It looks like the root is cut off, but that's not true. It's only artifact on the picture. Actually, you see combination of tuberpterygoid implant and anchorage in the floor of the nose, and you see how skillfully I missed the buttress. There's one implant medial to it, one implant distal to it. This was not the plan, but nevertheless it is successful. So there I can show you some examples of these methods. In the upper jaw, tuberpterygoid implant placement, and the second implant in the floor of the sinus. The next 3 implants are on the palatal side. I mean, you can't see this, but I remember the case. And in the lower jaw, because the patient had a severe class 2 skeletal relationship, I didn't put any implants in the distal mandible. It was not necessary, because anyway on those 5 implants the prosthetic construction was very, very distal, and so the patient came with a class 2 and she left with a class 2, so we didn't correct this. We just used the chance, because anyway there was not a lot of bone, no, as you can see. Okay, here you have the anchorage between the mentals. Then in the distal mandible you see lingual cortical engagement. The upper implants there, it's not so well structured. As you see, the implants on the laterals in the upper jaw, they don't reach the second cortical. Sometimes we have a very good bone there. In most cases we don't have good bone. In most cases only for the centrals there is good bone below the floor of the nose, but here this was stable. Another example for treatment. Some colleagues prefer to put 10 implants into the lower jaw. I don't think this is necessary as a rule, but it is a possibility. Double tuberpterygoid in the upper jaw on one side, one tuberpterygoid on the other side, combined with more implants. In general, if you have the chance to increase the number of implants from, let's say, 10 to 11 or 12, 13 is always a good idea, because this bone, also the corticals of the upper jaw are not especially good. When I was learning from Professor Scotecci, he was always saying never under-equip the maxilla. So always put enough implants into the maxilla, and I can recommend this also. I mean, this is a good sentence that you should take home. Well, this patient required full upper jaw reconstruction, and as you see in the lower jaw, the first molar was missing on the left side, so it was absolutely necessary to do also something in the lower jaw. I mean, the alternative would have been that we equip the upper jaw with teeth from 5 to 5, but this is of course, I mean, not a good idea if you do the upper jaw new. So that it was necessary to put those 3 implants. If we replace the last molar, if it's the first or second molar in the lower jaw, then usually we put 3 implants. We put 1 for each root, and then distally to that, a technical abutment in lingual or vestibular cortical engagement. So this is our approach. Okay, here's another example. It's a combination of BCS and KOS micro implants. I'm not even sure it's my case. Probably it is. Here's a segment in the upper jaw, also BCS and KOS micro. I mean, if you look at this picture, you might think I'm using BCS and KOS micro or KOS in general like 50-50. That's not true. I use 95% or 98% BCS and only sometimes this KOS micro. And I mean, there's no rule. Sometimes I just feel that the KOS would do it also. It's another typical case. You see segment in the lower jaw. We give to the patient teeth from 6 to 6 on both sides for equal mastication. So there must be the same amount of teeth, the same length of the teeth, and the same width. This is a segment which we did in a case where the maxilla was almost completely missing. 2 tuberal plywood implants, one 20 millimeter BCS implant in the stump of the zygomatic bone, and anteriorly the central was extracted in order to make a space for one implant. I don't recommend to connect those distal 3 implants to teeth on the front. I think this will not work, so I rather took the central out, and the lower jaw has to be also equipped. So this is an example. It goes into the direction of what Dr. Vivek has said. This is almost a maxillofacial application of the system. As I said, there are more methods. They have been described extensively. You see 10 methods and 13 methods, and maybe this method 14, engagement in the floor of the sinus, buttress engagement, should also be considered a separate method, so you can count it up and down as you like. I think if you manage the 7 methods which I have explained before, you will manage very well in strategic implantology. So this is what I had to say, and now I think Dr. Vivek wants to discuss questions, and so I'm ready for questions, and I hope I have an answer.